My name is David Dowd. I'm the owner and administrator of AlevCare Hospice.
My name is Shannon Wheeler. I'm a licensed nurse and clinical liaison with AlevCare. Hospice is a philosophy of care in which a person with a chronic, progressive, and life-limiting illness is provided specialized care at the very end of life. Well, if you're interested in hospice, the first thing we would want to do is talk to your healthcare provider. It's not going to be a surprise. You're going to know that you have a chronic and progressive illness. But as a person ends the final stages of life and they need more help, more assistance with their activities of daily living, and more symptoms that they need assistance with controlling, that's the time to ask your doctor.
I think one of the things that the Medicare benefit has done for hospice is to be really wonderful in that it doesn't cost anything. So there's no cost for a Medicare patient and there are no copays. What the benefit has really struggled to do is really educate people on what hospice is and what it isn't. And it's important to know that hospice doesn't have to be the last 2 or 3 days or 2 or 3 weeks of life. It can be, and it can be really beautifully administered during that short period of time, but it can be so much more. The hospice benefit is intended for 6 months of care, but there's no end date to it. So it can go beyond even 6 months. And the most regular feedback that we get from families is, I wish I would have known about hospice sooner.
That actually leads into one of the myths. I believe that almost everybody knows someone who has had a really hard struggle with a cancer battle, and that person has received treatment right up to the last few days. And then in the last few days, they elect hospice, and that patient can come on hospice, and then we get them comfortable, and they can pass very, very quickly. They've had cancer diagnosis sometimes for years or even up to a decade, and they've won out all their treatments. There's nothing else that's going to work. And that it is in contrast to someone who, say, for example, has a heart disease diagnosis, where the treatment for the diagnosis, because there's no cure, the treatment for the diagnosis is pretty much the very similar on or off of hospice. People sometimes don't realize that, and they kind of bypass that opportunity to even learn about that opportunity for the extra care that can be and support for the family that can be available in the last months of that disease process.
Yeah, another myth might be that with hospice, you have very little choice. And the truth of the matter is that hospice is all about choice. Nobody can tell you which hospice provider that you have to use. So just like maybe a PCP, you have the opportunity to choose that hospice agency that you would prefer, or make a switch if there's something that isn't going the way that you would like it to go, and you can opt to choose or switch to a different hospice company.
I think that another big myth in hospice is that you lose your autonomy, that you lose your ability to say, this is what my values are, and I want them observed during this, how my illness is treated. For example, there's a myth that, it's the last few days of life. We're just, and pardon me for being this direct, but we're just going to sedate someone with medications and until they pass. The patients and the family's values and their belief system and their goals for their treatment are integrated into the hospice program. So when you look at your desire for pain relief versus your desire for alertness, we're going to establish those values and try to target those goals that the family wants. Nobody's going to just zombify or zonk somebody, as we say, and then call it a day. We want the patient to be comfortable according to their values.
Another myth is that hospice isn't necessarily a final decision. So if you do begin to improve rather than decline once you choose hospice, you can take the Medicare hospice benefit and revert it back to Medicare Part A and go seek aggressive treatment and come off of hospice services and then seek hospice care again in the future if you qualify for it in the future.
I hear sometimes that people aren't very sure about what hospice provides and what hospice doesn't. Hospice provides all medications related to the diagnosis, the terminal diagnosis, provide any equipment that's needed along the lines of a Medicare formulary, nursing services, physician services, chaplain, social worker. We have a volunteer program. We have a veterans program that's wonderful. We have a pet therapist, our team, not to mention a nurse practitioner and our physician. Our team meets every 2 weeks and discusses every patient. And again, the values of the patient and the goals of the patient are made clear to the entire team as they work towards the goal of symptom relief and assistance with those activities that may be becoming harder. So it's you've got to know I'm a fan of seeing families change for the better because of that comprehensive relief that comes in. When someone is dealing with a terminal or life-limiting illnesses, the brain, the body, and the spirit go through lots of changes. Having somebody there that knows what to expect and the greatest fear is the fear of the unknown. If we can identify a potential symptom and say, look, this symptom is very common with this disease process. This is what's going to happen. And this is what we already have something in place, so we're ready to deal with it, whether that's the loss of the ability to walk or increasing shortness of breath. Maybe we have oxygen or medicine for shortness of breath in the home. In addition, our on-call staff, and this is every hospice, on-call staff is available 24/7 for questions about medications, for a visit if necessary. They hear terminal and they don't know. So somebody who's actually doing very, very well, they're 6 months out, their family is watching them sleep, afraid that they're going to stop breathing at any moment. We can say, look, these are the symptoms you're going to be looking for. We're not there yet. Take them for walks. So one of the myths, we were talking about the myths of hospice, I think because home health, Medicare home health has a requirement that you be homebound, that people often assume that it's the same in hospice. It's not. You can travel while you're on hospice, and we do have, I think the word is reciprocity, where, say, for example, you had a family member in Galveston that you wanted to go see as a hospice patient. You would contact a hospice in Galveston, and they would become responsible for the care of that patient while they're visiting. So travel is not just allowed, it's encouraged. One of the disciplines that I think often gets overlooked is the home health aide. That's a CNA or nurse's assistant. They're supervised by the RN case manager, who is the family's personal nurse. And they come in up to 5 days a week and provide anything from what I call a standby assist. So somebody's just a little bit wobbly, so they get the shower all ready, and then they stand out in the hallway and let the patient complete their own shower, and then help make sure that they're able to get dressed without falling and get them on with their day, all the way to a full head-to-toe bed bath. And for somebody that's in a coma, for example, the skills that they do are amazing. They shampoo hair, they shave, they brush teeth, they clean nails, and they're there as long as is necessary to get those tasks done. And I believe that if a hospice had a heart, it would be our CNAs. They often become so close to the families and what they do. And imagine, a lot of times when I get people signing up for hospice, they have been so weak or so out of breath or just so uncomfortable that they haven't showered in weeks to months. Getting in there and getting them their first real bath or shower, it's just like the person becomes energized and they feel human and humanized. So when you're managing pain in hospitals, there's different types of pain. So you're not going to try to treat muscle or bone pain in the exact same way you're going to treat nerve pain or gut pain. So a thorough pain assessment um, to locate the source and the origin of the pain determines what when discussing that pain control and therapy with the physician, what medications are used. And our goal is that we're going to keep on trying and trial the different and combinations of medications, again, based on the values and goals of the patient to come across that what works exactly for them, because no two patients are different. What's going to work for this person is not going to work for this person. So the origin of the pain, using combinations of pain medication, and we aren't, people get very, very scared at some of the names of the medications that we use, but we use small doses and we use conservative doses because our goal is pain relief, not to our satisfaction, but to the patient's satisfaction. And we are unlimited in where we can go with that. It's the only job I've ever done. I became a crisis care nurse or continuous care nurse right out of nursing school. And at my first shift, I knew nothing about end-of-life care, but I knew after that 12-hour shift that this is what I was going to do for the rest of my life. I don't think people realize that death can be, leaving this world is a spiritual experience, and providing that spiritual love and care. And I work for a unique organization that really allows us to express our spirituality and share in those spiritual moments with the patient. I don't mean that we're like suggesting or trying to make them go the spiritual route. We are, but just being spiritually open to those experiences that gives me goosebumps just thinking about it. But when you get somebody who's really uncomfortable, that hasn't had a shower, that they don't know the next thing that's going to happen, and you provide medication, education, equipment, cleanliness, peace of mind and comfort, that takes all of that burden off of the family so they can begin to have, no matter where they are, they could be 6 months out and then last another 18 months is common on hospice. But free them up to have those spiritual experiences, to kind of come to grips with the idea of, that I'm leaving this world, get to that place of acceptance. And sometimes you can get a patient and a family to a place where the patient has acceptance and peace. The family has acceptance and peace. All the symptoms are managed. Everything is going according to the patient's wishes. And you can actually have what I call a beautiful death, where the phase of it, the grief phase, the grief process, there's stages. You kind of hit that acceptance stage as the patient is leaving. And it can be really spiritual, where the family comes together and they say goodbye, but sometimes the presence of God comes, and it can be very, very beautiful, very fulfilling.